of the session is 60 minutes. First 10 minutes will be taken by Dr. Umair Ansari, who will be sharing his experiences with us. Dr. Muhammad Amir will be taking the next 10 minutes and share his part of the experience as well. Meanwhile, all of you can feel free to leave your question in the chat box. They will be entertained in the next question answer session of 30 minutes at the end, inshallah. Thank you. Now I will request Dr. Umar Ansari to open his mic and share his thoughts with us. Dr. Umar Ansari, please go ahead.
Assalamu alaikum, everybody. My name is Dr. Umair Ansari. I'm currently in USA. I'm a critical care pharmacist working at Suburban Hospital, John Hopkins Medicine, located in Maryland, USA. So I'll be discussing what the day in the life of a clinical pharmacist is. And if you are able to pull up the slides that were
Yeah,
provided.
sure.
So yes,
Yeah, sure. Let me.
definitely.
I'm just sharing my screen.
Sure. And I try to go quickly but efficiently through the slides in the given amount of
Yeah.
time. So we can go to the next slide.
Okay, yeah, sorry.
And I have no disclosures. So we can go to the next slide.
Okay.
And so if I just, giving you guys all a brief picture of what a clinical pharmacist is, we are working directly with a multidisciplinary healthcare team. And our main objective is providing patient care. And we come from different backgrounds. We're educated and trained in various disciplines and specialties in different environments as well. And that can include not only just the hospital setting, but that also includes outpatient clinics, community pharmacies, nursing homes, etc. So you can, obviously I'm specialized in critical care, but you have other areas as well. And, we are collaborating with physicians and or the healthcare system in general to perform these medication decision-making functions. And I'll go through what I mean by these medication decision-making functions in my next slides. And usually a clinical pharmacist will have some kind of residency training and or be specialized with a board certification. And, obviously in pharmacy, we have the pharmacy graduate post-year one residency program. Then we have a post-year two program. So you can be a general practice pharmacy residency, then you can subspecialize in a specialty pharmacy practice as well. We can go to the next slide.
Yeah, sure.
So what do clinical pharmacists in general do? So, I try to, in my best way, I try to summarize what our tasks are in general. So we're assessing a patient's health, patient-specific health status in any population, whether it's in critical care or the inpatient general wards, emergency department. So it all depends on how specific our patients are, what their clinical status and picture is. And from there, we'll determine whether their current medications are optimized or suboptimized. We'll evaluate the appropriateness and effectiveness of each medication that the patient will be taking or should be taking or should not be taking. We'll also help with recognizing any untreated healthcare problems that could either be improved or resolved with appropriate medication therapy. We'll also, since we have the patients admitted usually in the hospital, and for me, in the ICU setting, I'm able to follow these patients on a daily basis. So I can see their progress and see how the effectiveness of these medications will take place. And obviously, we have the entire healthcare team with us. We have not only physicians, we have nurses, we have other specialty uh, doctors, we have nurse practitioners, we have physician assistants. All of us are a part of a team. So we're all working together in terms of selecting the best patient specific care and medication therapy. Also, if we're able to, we are also educating and advising patients on how to best take their medications. Uh, we can go to the next slide. And so the next question is, how do clinical pharmacists provide patient care? So our main focus is, like I've mentioned somewhat, we focus on appropriateness, effectiveness, and obviously the most important thing would be the safety of patient medication use. Um, we apply our specialized knowledge of scientific or clinical knowledge use of these medications and determining if a certain medication is needed. Sometimes we can be asked questions on, what maybe a mechanism of a mechanism of action of a medication may be. What could a dosing be for a patient? And keep in mind, because I'm in the ICU setting, so dosing, mechanism of action, all of these things are very important for me because my patients usually are very unstable. So when I have very unstable patients, I have to frequently evaluate my patients dosing, and that can be because patients can rapidly deteriorate and they can have any kind of impairment in terms of the liver or the kidney, or hemodynamic instability. So all of these things are very important to my practice and in general, of course. But I have to be evaluating dosing, adverse effects, drug-drug interactions, uh, maybe even multiple times in the day. So it's very common for me to do this. Obviously, we're using evidence-based medicine to manage and solve healthcare problems or issues that may arise. And then we also tailor advice to best meet a individual patient's needs. So that can be based on maybe a patient specific request, or maybe a patient having difficulty maybe taking a medication a certain time of the day, or the dose. We can individualize therapy as well. Next slide. So my daily responsibilities, I know this looks like a lot, but I just want to very quickly summarize. So my daily, uh, I guess a day in the life of me and my responsibilities are rounding with the ICU medical staff, providing daily clinical and operational support to the ICU, helping facilitate drug dosing services using a hospital per pharmacy protocol policy. What I mean by this is we have certain medications, um, certain therapeutic drug monitoring that we have under our pharmacy protocol. When we are consulted, we can and we are allowed to dose medications a certain way. For example, an antibiotic such as vancomycin, or antibiotics such as aminoglycosides, even anticoagulation such as unfractionated heparin are just some examples. Providing parenteral nutrition support, I am designated in my practice to be in charge of providing parenteral nutrition. So I provide either TPN or PPN support for my patients. I also assess and verify new medication orders for appropriateness using our computer physician order entry system. Also, I participate on the Code Blue team. So I respond to Code Blue situations when they do arise, not only in the ICU, but in the entire hospital. I serve as a drug information resource. I precept our PGY1 pharmacy practice residents, which we have currently, two of them, and I've helped to provide education to pharmacists, physicians, and nurses, and this can be provided either by in-services or continuing education, or any kind of lecture that needs to be given, or any kind of education that can be given. Also, I'm involved in several multidisciplinary hospital-wide committees. This can include the Pharmacy and Therapeutics Committee, the Residency Advisory Committee. In the past, I've also been involved with the Hospital Sedation Committee. So these are just common examples. I'm also involved with the Critical Care Collaborative Practice Committee, where we discuss critical care issues as an entire team, and we do this on a monthly basis. So any issues that come up, I myself represent pharmacy in that meeting, so anything that comes up, we will share. And then also continuously evaluating clinical practice using medication utilization evaluations, or MUEs. This helps us determine if there is a medication that may be causing some kind of adverse effects, or if you just want to evaluate any kind of medication in specific, you can do an MUE on a certain medication and see if it is being used efficiently, safely, but do this on a continuous basis. So I've been a part of this too. Next slide, please. So very quickly, my daily tasks and duties, time management is priority. I think time management is extremely important, and it takes practice and experience to gain time management skills, because you have to be able to prioritize your daily activities. Not only do you have to be proactive, but you have to be proactive in everything. So whether it's optimizing pharmacotherapy, serving as a team manager, team member when responding to code blue situations, documenting clinical interventions, writing progress notes in the electronic medical record. Also, one thing that's also very important right now, and especially in terms of the COVID crisis, or in terms in general, being aware of drug shortages, or that's very important right now, because obviously we're utilizing a lot of different medications, things and drugs that may not have been so common before, we're utilizing now even more during this whole COVID crisis. For example, maybe we're utilizing different drugs, such as it can be anywhere from sedative medications or pain meds. So those are just some examples. I don't want to go into too much information, but also we're looking at cost-effective or therapeutic alternatives to medications as well, because we also want to be cost-effective with choosing which drugs to be able to use. Um, Also contributing to critical care projects, such as creating optimizing drug protocols, hospital-wide policy procedures. This can include order sets in the our electronic medical record system, guidelines. So I'll try to go further into this in my next slides. And then obviously being involved with publications or any kind of research and resident projects is something ongoing and longitudinal as well. Next slide. So this is a picture I just wanted to show you, is kind of like showing you an example of a mnemonic device called Fast Hugs BID. There's an S at the bottom. It's not showing on the screen, but I'll tell you guys, this is kind of my daily basic 101 assessment of every patient in the ICU or critical care setting. So it's kind of showing you what I kind of do on a daily basis besides everything else. So this is like the basics to start with each patient, where you evaluate each of these different situations for each patient. So, very quickly, I'll assess if a patient has any feeding. Analgesia, because I want to make sure a patient is not in pain. Sedation, I'll evaluate if a patient needs to be on sedation, what type of sedation. And all of these I also need to know what dose they're on as well. Thromboprophylaxis, because we want to make sure we are preventing any kind of VTE from occurring if they're immobile. Head up position is the elevation of the bed that we may want to be for the patient at a specific degree. Stress also prophylaxis, we'll also evaluate that. Glycemic control is important because we want to make sure they're not hyperglycemic. Also, we want to make sure they're not hypoglycemic as well. The S at the bottom, which is not showing on the screen, was a spontaneous breathing trial, or SBT, which in my setting in the ICU is evaluating if patients need to be weaned from a mechanical ventilator. So if I have patients on a mechanical ventilator, they need to be evaluated if they're able to, on a daily basis, and they need to be recommended to decrease their ventilation so that we can help wake them up. And I can also help with this and recommend whether a patient needs to uh, decrease their ventilation, so that we can try to evaluate a patient being able to breathe on their own. Um, Bowel care is basically making sure our patient is having bowel movements in the ICU setting, because we don't want to have any kind of constipation. Indwelling catheter removal is referring to lines that the patient may have, uh, whether it's a urinary catheter, whether it's some kind of peripheral line, or even central line. If we don't need any kind of lines, we can always evaluate them as well for our patient. And de-escalation of antibiotics is also very important for us, because we are constantly evaluating antimicrobial resistance, and we don't want to use antibiotics when we don't need to use antibiotics. Next slide. So this is just, I just wanted to show you that there was a study that basically um, evaluated the impact of a clinical pharmacist enforced intensive care unit sedation protocol on the duration of mechanical ventilation and hospital stay. And here, what they concluded was, if a pharmacist is present and enforcing this direct intervention in the ICU using their sedation guidelines, that this resulted in significant decrease in the duration mechanical ventilation in patients receiving continuous sedation. So what is this is showing is, if there is a decrease in duration of mechanical ventilation, what that is going to equal to is decreased length of hospital stay, and most importantly, it's going to decrease any costs associated with the hospital as well, because we're going to reduce the use of mechanical ventilation. Next slide. And this actually is just a short, it was a short communication published by me and my previous colleagues when I was a pharmacist actually working in Saudi Arabia in the clinical, in the ICU setting as well. So this, if you guys have a chance and moment, please look at this. Well, it was my experiences in the ICU clinical ICU setting in Saudi Arabia.
Sorry, Dr. Umar, to interrupt. We are out of
Out
time.
of time.
Please,
Okay,
if yeah,
sure.
please, you can wind up.
Yeah, yeah.
Sorry.
Yeah, next slide. Next slide. And this is basically a picture of something that, oh, sorry, the previous slide, very quickly, I'm just going to mention, these are just, this is a medication for procedural sedation analgesia chart that I created when I was a part of the hospital sedation committee, just showing you what I did with medications and how I helped the committee evaluate and make a decent chart. I can share this all with you later on if you like. Next slide. And then this slide is an in-service that I provided to the nursing about propofol and dexmedetomidine, which are sedation medications, and teaching them the adverse effects, the doses, all for the nursing staff. Next slide. And I think we're out of time, but I had a patient case at the end. We don't have to go into this now, but it was just a patient case where it was showing it was a unique patient case with pheochromocytoma. This is a type of hypertensive emergency, and it was just showing some of my treatments of how I made some of my recommendations. But obviously, this can all be discussed, but we can go to the next slide. And just my recommendations, we can discuss this later, but I'm done for now. Thank you very much.
Um, Thank you, Dr. Umar Ansari, for your precious time. Now, I would like to invite Dr. Muhammad Amir on the mic to share his thoughts. Dr. Muhammad Amir, please go ahead. Should I share
Uh,
your slides or?
appreciate Ma'am, can you hear me clearly? Is that the voice okay?
Yeah, it's clear.
Thank you for confirming that. Yes, kindly share my slides.
Oh, sure. Give me a moment. I'm just sharing my screen.
Sure, that's all right. Take your time. In the meanwhile, I like to thank the committee for selecting me and giving me this opportunity to share what is my perception about the clinical pharmacist is and how our daily life goes on for a clinical pharmacist. Currently, I'm working as a manager pharmacy for the Lady Lady Hospital, that is a public hospital in Peshawar, in Pakistan. Uh, I was a clinical pharmacist and I was a clinical pharmacy specialist earlier before that particular one. So next slide, please. There's nothing to disclose in this thing. There's no financial factor or commercial one, and there won't be any treatment discussed during my slides. Next, please. All the information will be shared during this presentation would be my personal experience of 10 years or in national and international one, and most of it is based on a paper that I wrote for 2012 and still working on it on those ones. Okay, next please. Before I start telling you guys that what does a clinical pharmacist do in a normal routine, I would like to share my perception about a clinical pharmacist. It is based on the category of of knowledge. The knowledge is categorized into three types, that is explicit, implicit, and tacit knowledge. Based on this factor, I define clinical pharmacist as the pharmacist having the explicit knowledge of drug use and have expertise to convert this explicit knowledge to implicit knowledge and gain tacit knowledge for the benefit of patient health. Just to make it much more easier, can you please click Mr. Umara? Next one. Yes, next again. Okay, if you no come back, if you can come back on. Okay, now if putting it into simpler words, what I try to say and what my perception about the clinical pharmacist is a pharmacist having a book knowledge of drug use and have the experts to convert this book knowledge to patient-based knowledge and gain experience-based knowledge for the benefit of patient health. This is all about what the clinical pharmacist is all about. That to use that knowledge and use it for the patient wise and to gain new knowledge so that we can use drug more efficiently and more apparently for that particular case. Next, please. Uh, this is the basic skills that I believe that all the clinical pharmacists should have. You will see that there is no knowledge is not mentioned as the primary one. The reason that is because it is a prerequisite. Knowledge is a prerequisite for a clinical pharmacist. So, from my perspective, primary skill that all the clinical pharmacists should have is communication that includes the verbal and written as well. We all know that we have to communicate not only with physicians and the public, but also with management, and especially on emails. So that is very important that all the clinical pharmacists who aspire to become a clinical pharmacist should have very strong communication skills. The secondary skills that I believe that all the clinical pharmacists should have, and as Dr. Omer was discussing, that it should be research and the training and development. Uh, Many of the times I hear that research is considered as an academic skill, but believe you me, at this current time, and especially in the COVID side, that tocilizumab, hydroxychloroquine, all these things, we need clinical pharmacists on the front hand to have research on those things. Training development is an essential part of a clinical pharmacist because not every information can be converted into literature. Not everything can be done into a paper. Hence, it is very necessary for a clinical pharmacist to train other on their tacit knowledge. Next, please. Based on all of my perception about the clinical pharmacist and the skills that I require, this is my normal routine. To be honestly speaking, I'm a morning person. I get up early, very early in the morning. It's 5:30 a.m. I'm one of the big major reasons, but there's no call for roti or anything or wake up early morning, there is no one to disturb me at the time. This is my updating time. I usually update my knowledge at this particular from 5:30 to 7:30. I go through all the literature that I need to update my. I need to go through from it and to update my knowledge. I usually reach hospital about 15 minutes earlier, and after that, I do a pre-round preparation. At that time, when we were becoming clinical pharmacists, we used to carry four books in our pocket, a handbook of clinical medicine, Oxford handbook of clinical medicine, DNF, and other pocket. But this time, our great for clinical pharmacists, we have smartphone on our hand and many books on PDF available. So it is getting much more easier for us. So this pre-round, earlier it was about 2 to 3 hours. It used to take us 2 to 3 hours just to get prepared for the rounds, and now it is much more easier at this time. So it takes less than an hour, to be honestly speaking. Uh, After preparation, then I go and attend my rounds. We know that in the rounds, as Dr. Meres also has discussed, that it is a multidisciplinary people, or different professional people out there, healthcare professionals, there, the physician, nurse, nutrition, all are along with us in that particular one. One advice that I'd like to give is to be patient in that particular round and listen to all of them and try to speak at the end and see whether and contribute at the time when it is the most needed one. What happens that the youngsters, the clinical pharmacists, what they do, they eagerly say that okay, and although the physician already knew about that thing. So I just my suggestion is I stay at the back and listen that okay, if the physician knows that there is a concern or not, if the physician is unable to identify that concern, then I will say yes, there is a concern of medication, and you get your respect on based on those things. If I get lucky after the round, if I get lucky, I will have lunch. Many of the times I use this particular time for social activities, getting to know my physicians, nurses, and get to know my people around me. After lunch, there are many special assignments that we have. To be honestly speaking, we have physician queries to solve, policy development, research work. There are many assignments to be given on this particular one. Uh, Officially, we worked. Officially, it's till 5 o'clock, but not officially. We are very used to working till 7 o'clock. To be honestly speaking, I am still working till 7 o'clock. This is my normal routine. Uh, uh, at the end of the day, I try to find out literature that I need to read for the next morning. I prepare it for the next morning one. That what I need to read in the next morning and to update myself. What I'm lacking. What is my knowledge gap is. Training and development. I usually, I most of the time, the clinical pharmacists are involved in training and development, and if there is a session to conduct or not, and how to plan for training and development sessions. So we are involved in that particular one also in very much of that. Next, please. Here you see a slide. Primarily, many of you will think that this is a family discussion going on. There's a doctor, father, doctor, and there's an elder brother and mother who is discussing about the family matters. But that is not true. This is next, please. Uh, Actually, this is a virtual multidisciplinary round that is happening. Next slide, please. Next. This is the thing that is back a bit back. Okay, this is the future of things. Not everyone need to be physically present. At our time, it was we have to be physically present. Due to technology, things are changing. Pharmacy informatics, health informatics is bringing new things and updating many different ways, changing the paradigm completely. So this is the new things. You can see that we all are discussing patient. Every patient is discussed virtually on virtually rather than being on physically present and those things. Next, please, Mr. Mema. So this is a multidisciplinary down that was done. Next, please. In 2000, these are good days. This was at my earlier days. In this decade, we used to do all these things. But for the upcoming inspiring clinical pharmacists, I would recommend that they should update themselves with pharmacy informatics and things like that. So this decade will completely change, will change based on pharmacy informatics and health informatics. So we need to upgrade ourselves with respect to that one. Next, please. New era clinical pharmacy, we have to know what's going to happen. To be honestly, what I assume that the dispensing process will be completely will be the domain of pharmacy technicians. It will be taken from the pharmacist, and pharmacists will be responsible for ensuring medication use, optimal use in patient. In Even technicians are being experimented for the clinical pharmacy documentation. There is experiments going on in different parts of the world that to ease the work documentation work and make clinical pharmacists much more available for clinical perspective rather than the non-clinical activities. I see that clinical pharmacy specialization will create. It is already being established in US and other things, but however, it will be more consultative based rather than one. Like for, I do believe that what will happen that they will find that there is a particular issue, drug use issue, and they will consult people of different specialty on both geriatric pharmacotherapy, MTM, infection diseases. They will consult. Not every patient, again, not every patient requires a pharmacist input, and the time is wasted. To be honestly speaking, at the time that okay, if there's nothing, especially in the surgical care unit, there is only three category of medication are being used, and they're less likely. If all the things are being arranged, the doses are correct. There's nothing much one can do on those things other than reconciliation. So again, so the future is going towards the consultation towards the pharmacy one, and that is what we should be looking after. Next, please. Hard fact to realize that all inspiring clinical pharmacists should realize that the physician will not respect you because of your degree or the doctor title, to be honestly speaking. Legally, in Pakistan, I can ensure you that in the Middle East also and many other places, the physician is responsible for the patient use and its outcome. It's not yet on the pharmacist or things like that. Things are changing. I'm pretty much sure of that thing, but still, it is now. It is under the domain of physician. Physician will trust only based on his own judgment and ideology. Once he gets a trust, believe you me that a clinical pharmacist will boom like hell. He will be called upon. I have just seen you. I have just shown you about the picture about 2 slides ago. Let me assure you that it is of a public sector. It is of public sector one. Last hard fact to realize that the ward is a territory for the physician, not for pharmacy. For pharmacy, we should respect that particular one when we go to the territory, and we should work among. And there's protocol and culture that we need to follow on those things. Next, please, Mr. Mano. So, lesson learned. To be a clinical pharmacist, it's a good clinical pharmacist is respected in any clinical institution, whether it is public, non-public, private, developed, non-developed country, anywhere. Clinical pharmacist with good clinical knowledge, along with skills and good communication skills will be prior. Again, reminding you that the slides and the things that I have shown is of public sector or one of the largest publicity, especially in KPK. I'm talking about KPK. Yeah, I'm not talking about Karachi also or any other places. And here, when we have started the clinical pharmacy round, it is 99%. Within one month, the intervention, the acceptance of intervention for the pharmacist was 99%. And once a the last thing is clinical pharmacist. Once you become a clinical pharmacist, you have to remain a clinical pharmacist throughout the life. They will expect you to be updated, to be knowledgeable. Every now and then, they will meet you, and they know that you have worked as a clinical pharmacist. They will ask you queries to okay, what is your opinion on this medication? What is not opinion? What is your opinion? How you will deal with that thing? Uh, that's it from my side. I think so. Yeah, I think it's the last slide. Yep, that's it. Thank you very much.
Um, Thank you very much, Dr. Muhammad Amir and Dr. Umar Ansari, for enlightening us with this knowledge. I'm sure many of us have learned a lot today. Now we will move towards the question answers session. I'll quickly read out a few questions for which if you could give precise answers. So there is this Mariam Ahmed that she says that hello, may I ask a question? I'm currently a BPharm student and wanted to know your opinion regarding further studies, especially about masters. It's Mariam Ahmed.
To whom it is directed, Ms. Vimana? It is directed
Um,
to.
she did not mention any
Dr.
speaker.
Muhammad Amir, if you can answer, because she's asking from for Pakistan, if she can do something.
Well, honestly, in Pakistan, the PharmD is the last degree. To be honestly speaking, PharmD is the last degree for pharmacists, and you do not need to have an MPhil as an academic degree. We have residencies. Luckily, many people, many institutions in Pakistan are trying to develop residencies, accredited residencies. If I can recall, Shaukat Khan, Aga Khan, Shifa are going for internationally accredited training programs. There are many other also in this and different hospitals. There are different. So I would recommend people to go for a training program. My request to all youngsters is to at least take 4 years of a hospital. Not everyone can. Again, it takes time to become a clinical pharmacist. It will take minimum 4 years. If you have seen the BCPS requirement also, it takes nearly 4 years. You have to know the hospital use and how it is being done. So have some experience in hospital, at least 2 to 3 years. For my recommendation is at least 3 years should be in a hospital setting or hospital setting, and then you can work out towards the clinical role.
Thank you. Okay, there is this one other question. It's a general. Any of the speaker can answer. It's Sahar Imam. She says that what should we do after PharmD if we want to go in research field?
Uh,
So sorry. So
Mr. Omar,
the question was after completing Farm D, what to do in terms of going into research? Is that the question?
Yeah, like she wanna ask that what should we do after PharmD if we want to go in research field?
Yeah, I'll try to say a few comments and then Dr. Mohammed can say what he wants to say. But I guess, I mean, if you're able to, obviously I'm speaking from a U.S. perspective, but uh, um, if a PharmD, even from here, wanted to go into research, obviously you have the industry side of pharmacy as well, but that's a completely different category of work and research related. But obviously, there's also projects that you can be involved in. If you have any associations with physicians or other colleagues of yours in the hospital setting, or even in the school setting of your university or college, uh, there's always research going on. There's always projects going on. Talk to your preceptors. Talk to your professors. See what their ideas are. Maybe they could be having some research actively going on and you can actively participate with them.
Thank you. So, Dr. Muhammad Amir, do you want to share your ideas?
well, honestly, if someone wants to become a researcher, a scientist, or clinical practice, or a drug scientist, they need to have a degree with respect to that. I don't think so. The PharmD degree make qualifies you to become a researcher. To be honest speaking, it's more of a practicing based degree. So if someone wants to be in the research, they have to get a higher degree of MPhil or masters with respect to that thing, and then go for PhD. That would be a better appropriate pathway, carry pathway.
Okay, thank you. There is this other person, Rehan Malik. It's for Dr. Muhammad Amir. Okay, he wanna ask that how can we promote special courses related to clinical pharmacy in Pakistan, other than masters, such as workshops related to clinical pharmacy?
Oh, that's a good question. In fact, yesterday I was talking to one of the Canadian professors. The issue currently in Pakistan, we do not have courses, validated or accredited courses in Pakistan from Pakistani perspective. And the courses that are being offered outside online from ASHP and other ones, from my perspective, it's very expensive. $700 is too expensive to for a young graduate, to be honestly speaking. We need to work on those things. If someone have some sponsorship and they have financially sound enough, there are now online courses available. from ASHPs and other institutions or societies that they can go for. But again, yes, we need to. It is mandatory and it should be done in Pakistan that the university should come across and develop courses. Small. I'm not saying a whole huge courses, but small courses, certificates for specializations.
Okay, thank you. There's this other question, Mariam Ahmed. She wanna ask that can an international BPharm student apply for residency program in the Pakistan?
Mm. Yes, shall I?
Yeah, please.
Yes, go ahead.
Yes. Oh, thank you. Thank you. Yes, really. I don't think so there is a necessity. You don't have any, as long as you have a license, and Pakistan does not have so much stringent policies on those practicing, like in developed countries or other countries, they have a stringent policies for observationship or traineeship for licenses. Pakistan do not have such things, so yes, they are most welcome to come across to Pakistan, and that would be a good thing.
Okay. So I think there are no further questions with us. So thank you all. Thank you giving back to pharmacy in Pakistan. Thank you, Dr. Umair Ansari, and thank you, Dr. Muhammad Amir, and everyone else who helped to make this session successful. I'm sure everyone is satisfied with their queries now. This was a successful session, and we look forward to many more learning opportunities given to us by Giving Back to Pharmacy in Pakistan Forum. Thank you once again, everyone. Keep washing your hands and have a healthy and safe life. Take care. Allah Hafiz. Should we?
Wait, the speakers can wait 2 minutes.
Okay, sure.